Welcome. Oh, oh, now the recording started. Okay. Um, Welcome to the Center for Suicide Prevention and Recovery's monthly suicide research spotlight. We're really excited this month to have Dr. Courtney Bagge and Dr. Andrew Littlefield join us to talk about their work on on a sample with pronounced risk of suicidal behaviors, particularly patients who are discharged from a psychiatric hospital after a suicide attempt. The main goal of their work was to determine whether subgroup membership, which is characterized by different patterns of behavioral warning signs for suicide attempt, could predict serious suicidal ideation and behavior 12 months after the patient has been discharged. Dr. Courtney Bagge is a clinical psychologist and associate professor of psychiatry at the University of Michigan Medical Center and an investigator with the VA Center for Clinical Management Research at the Ann Arbor Healthcare System. Dr. Andrew Littlefield is an associate professor at Texas Tech University, and broadly his research focuses on factors associated with substance use and misuse. And so, yeah, without further ado, let me pass off the microphone, I guess, unmute myself and pass it off to Dr. Bagge and Dr. Littlefield.
Can everyone see my slides? Awesome. Okay, so I'll be talking first, then I'll be passing it off to Dr. Littlefield. And before I say anything, I'm under the weather, and so I apologize. I'm a little nasally, and I'm having some issues with hearing everyone, it seems like, except Andrew when he talks. And so for any kind of questions, I might have to someone repeat it. I could hear you previously just a little bit, so I apologize if I am not reacting as fast. So, but I am so excited to be here. I see a lot of familiar names, and it's been a long time. So I will just jump right into it. I'd like to acknowledge my grant support for the project I'll be talking about, which was the Military Suicide Research Consortium, which was part of the Department of Defense. The first one is our baseline study, which I'm going to briefly review, and then our long-term follow-up, which is the focus of this talk. Okay, so warning signs. Okay, this is kind of my bread and butter. So we know that a top priority for the National Action Alliance for Suicide Prevention is to predict suicide risk in the near term. So we're talking about near next hours or day. But really, if you're looking at kind of the bulk of research that has been done to date, it's really focused on identifying who is at risk rather than when. So characteristics which don't vary day to day. For instance, maybe based on biological sex or some kind of diagnosis. And I would say as a clinician, we're interested not only who is more likely to attempt, but when. Why did a patient attempt today compared to a previous day when they were also at risk, but they didn't attempt? And as a clinician, think about it, anyone that comes to our office is going to be at increased risk for suicide attempt, given that they have a mental health condition. What was unusual or different for a particular patient? And controlled research in this very near-term risk is pretty sparse. So focus on when. Just as an example, so if you're looking at an alcohol use disorder, that would tell us who is at risk. These are characteristics that don't vary today. It's comparing two subgroups. When you're thinking about when someone's at risk, you're really looking at the timing of attempt, things that can vary hour to hour or daily. So whether someone was drinking, acute alcohol use is that. In order to really get at this, I would say that you need two things. One is a measure of acute suicide risk, so something that allows you to really look at things that changed hourly or within a day. And then also a within-person design, so you can look at changes within your patient. So something that I developed is the timeline follow back for suicide attempts. And for those of you who are not familiar with it, it's based off of the timeline follow back for alcohol use. which looks at alcohol use up to a year. Instead of looking at days going back, we recreate the 48 hours prior to a suicide attempt, and only this is administered for people who have been hospitalized for a suicide attempt, and we assess them then within 48 hours. So what you do is you ask them about who they were with and what activities, and you really recreate this timeline. You ask them about things that are important to you. When did you drink alcohol? When did you start drinking? When did you end drinking? Oh, you got in this fight. When was that? And we've actually expanded it to look at intensity of affect and cognitions, which is not going to be the focus of this talk. I just wanted to mention that. So we can ask them, okay, let's review the whole timeline. You said you were, at your grandma's house watching Jeopardy. What was your intensity of suicide ideation at that point on this scale? Oh, it was a 0. Okay. And then you can kind of track it. So in terms of design, in public health, they have this beautiful design called the case crossover design, which was actually made to determine near-term acute factors for heart attack, like shoveling snow. And so instead of looking at 2 groups of individual, you look at 1 group of individual. I don't know if you can see my mouse. That's okay. The case period, so let's say the day of the suicide attempt, you can look at that and see whether something occurred. Let's say, did someone drink? And you can compare it to a proximal close day, like a control period, a day before, where they were also high risk and didn't. And ostensibly, if alcohol was a risk factor for suicide attempt, a warning sign, it would occur more often on the day of than the day before, as far as near-term risk. What's nice about this, it's really focusing on the individual. Okay, so the baseline study, I'm just briefly going to review some of the findings for behavioral warning signs. We had a multi-site study, had 349 individuals who, again, presented at the hospital very soon after their suicide attempt. We had 2 civilian and 3 veterans hospitals. We performed the timeline follow back for suicide attempts. And what I'm going to be focusing today are behavioral warning signs, which was a very big interest to our funder, given that they're potentially observable or more likely to be observable. Here's a list of some of the ones we looked at. With these findings, it's important to know that there was no interaction, so no differences in warning signs found by veteran status, sex, age, race, or ethnicity. So this is just a quick overview of some of the behavioral warning signs that we found. What I want to do is orient you. Hold on, I can't really see my slide. In green, this is our control period. So this is the day before. So it's the percentage of individuals that experienced whatever is on the white column. And then pink is the day of the attempt. So that's our case period if we're looking back to that figure. So for instance, 33% of our group said that they communicated, had suicide-related communicated to another person, particularly if they wanted to attempt or was talking about their death or dying, compared to the day before, 13% of the group. So that's just a descriptive for you that will be relevant as Andrew presents. But what I want to show you, what matters is the odds ratio, which is actually within a person, not looking at percentages for the group. And you can see that all of these here, suicide communications, preparation of personal affairs, alcohol, other risky behaviors. This can look like unsafe sex, damaging property, impulsive spending, and interpersonal negative life events pose increased risk for attempting, soon after attempting. Oh, it's not now going to the next one. Okay, so that's just a bleep, because now we're going into kind of the main focus of the talk, is that after this grant was finished, this project was finished, the baseline, Andrew and I were, discussing that this group that I consistently evaluate, people who have recently attempted suicide, we were pretty worried about them. And this is because they're recent attempters. They're on the psychiatric inpatient unit for this attempt. And we know that post-discharge, you're at a substantial increased risk for suicidal behavior, particularly in the month after, and the risk remains up to 12 months. Now, looking at the literature, there are some things that have shown to predict reattempts in this population. And that is having previous attempts. So it wasn't your first attempt. When I'm going to talk about index attempt, meaning the baseline. You have a depression diagnosis, maybe problems with alcohol use. And then also in your index attempt, a negative reaction, meaning that, that they regretted that the suicide attempt wasn't successful soon after. So really, this is not news to anyone here, is that determining who is at risk post-discharge remains a difficult endeavor. So Andrew and I started thinking about this and said, okay, so wonder, is it possible, can we use the when, these behavioral patterns we just talked about, behavioral warning signs, to inform the who? Can we determine if there are groups or classes of individuals with similar patterns of these behavioral responses soon before the attempt that can predict what we're interested in, a future outcome, like reattempt or serious suicide ideation? But alas, you know, it's like 3 years later. We do our classes. We're really excited, you know, but you know, these things cost money. But then angels sing, and somehow this is also of interest to our funder. And they approached anyone that had funding in the first round and said, will you write a proposal? Because we really care about what happens to each individual. So Andrew and I were like, this is great. It's not very much money, but we are going to make something happen. And so we proposed to do a long-term follow-up to this baseline sample. We already had our classes, and what we were asking funding for was to be able to follow them up and then conduct these analyses. So the key questions that I am going to be discussing today, Andrew and I are discussing today, excuse me, are: can behavioral warning sign groups predict future attempts and severity of suicidal thoughts during this pronounced period, so 12 months post-discharge of hospitalization? And can they do that over and above traditional risk factors, like the ones I just described: depression, reaction to the index attempt? Okay, so the first thing, we received the money, yay. But I want to acknowledge that the baseline study ended in 2017, started in 2013, okay? This study started in 2018, the long-term follow-up. So it's been a number of years. We've been tracking these individuals since we've contacted them. So luckily, Kate Comtois is a genius and talked to me before when I was doing the baseline study and said, we really should get permissions to follow up these individuals. And so we did. And so we had permissions to, in these various scenarios, to contact individuals. Okay, how did we do? So we had 181 that gave us permissions from the largest site, which was my site, University of Mississippi Medical Center. 181 is actually 86% of anyone that participated from my site in the baseline study. Why I'm highlighting that is that I did not have PHI for the remaining sites, so I wasn't able to follow them. So it's all focused on this number. So the target is 181. So we were able to locate 86% of the target. So about 26 people we are never able to find. Once we've located 6%, we're not eligible for a follow-up, which sounds a little weird, right? Not eligible, but we're following them up. It's because we wouldn't have been able to interview them due to that they were deceased or in jail. And one person had a power of attorney. So 95% was eligible, and then we had 90% of eligible that consented. So overall, 73% were able to find. And here's just some information about from baseline to follow-up interview, that the max was 5 years when we're trying to find people at the bottom there. What I can tell you is that the individuals that participated, the 132 and the people that did not differ in any of the baseline characteristics, including the behavioral learning science classes that Andrew will be talking about. I'm going to go through this fairly quickly, but given that we're talking about classes, I wanted you just to see what the overall rates were. So we had about 71 female, majority were white, a large percentage African American, which is very consistent with Mississippi. The baseline characteristics for the PHQ-9, a mean of 15 is moderately severe, and then a little under what our standard is for problematic alcohol use. It's usually about an 8 as far as the average for the sample. Most people had a little over half had a history of a prior suicide attempt, and then most people veered towards, I am glad that the suicide attempt was not successful. As far as our follow-up procedure, we use the URAP, which I'm sure everyone is very familiar. It's a risk assessment protocol that kind of wraps the assessment. This was a phone assessment. And remember, even though it was 5 years later at the longest, we were really focused on this 12-month period prior. So we used the SASE count to look at a presence of a suicide attempt. And we oriented them, of course, to the 12-month period of interest. We looked at the common data elements for our funder, and there was one item that looked at frequency of suicide ideation. And then we used the SSI worst, which is the level of the worst suicide ideation in that 12-month period. We paid them $35 and also gave them a $15 bonus if they completed the interview when scheduled. Okay, so the overall descriptives of what we found for those 132 people is that 23% reattempted. We have onset just in case people are interested. So the average onset to that attempt among the 30, it's about 5 months. Frequency of SI was about a 2. And the level of worst ideation, just in case people are interested, that was the SSSI. So now I'm going to hand it over to Andrew. And Andrew, if you just want to ask me to forward the slides, I can do that.
Sounds good. Thank you, Courtney. Can you all hear me okay? All right. So to identify these subgroups of participants that showed similar patterns of behaviors in the hours leading up to the attempt, we use something called latent class analysis. This is a subtype of mixture modeling, but it's an approach that we can use instead of trying to focus on a variable-centered approach. So maybe we have a latent variable such as extroversion we're going to identify. Instead, we try to find latent or kind of hidden subgroups of people that show similar patterns on assessments that we're interested in. And the behaviors we were interested in for this project were 7 categorical variables. How did we choose these variables? It was based on prior research that was interested in warning signs. It was also based on kind of statistical necessity. There had to be a certain overall frequency of endorsement of these behaviors in the sample so it's feasible for us to do these analyses. So the variables was alcohol use. So this would be any alcohol use, binary yes, no. Did we have nightmares? Yes, no. Interpersonal negative life events, also a binary variable, yes, no. Suicide-related communication. So this could be communicating about your suicide attempt via text, via phone, or in person. Risky behaviors. So this included things like unsafe sex. And then a sleep variable that we captured those who might be sleeping too little versus what we kind of have a target for between that 6 to 9 hours. So less than 6 hours versus 6 to 9 hours. And then people who might be sleeping too much. So greater than 9 hours versus 6 to 9 hours. All right, next slide, Courtney. All right, so those variables we talked about, there's two important periods that we're concerned about, just like Courtney explained. We have this case period, so this would be the 24 hours immediately before the attempt, and a control period. This would be 24 hours before the case. So in total, we have data in the 48 hours that precedes the participant's attempt. When we can look at latent class analysis, it's kind of similar to factor analysis, where you decide, well, is there one factor, two factors, three factors, however many factors? Same idea here, but we want to see, well, how many groups do we think are best represented in the data? So we examined 2 to 6 class solutions. We compared the classes on all sorts of different types of model fit to see which best matched the data. If you've ever done this before, you probably know that when you compare classes on model fit, different indices or measures of model fit don't always agree, but we got lucky here that whatever indice we used all suggested that the 5-class solution was the best. One really cool element of this is when we conducted this latent class solution to identify these 5 groups of participants that showed similar behavioral patterns in the hours before the attempt. We did this using the baseline sample. We were completely blind of who we might be able to recruit in the follow-up study, what their outcomes might be. So this was a true prospective analysis. We had these solutions beforehand and had that well defined. Once we identified these 5 classes, we compared it on our study outcomes, which would be what Courtney described when she was giving the overall statistics for the entire sample. So the prevalence of reattempt, suicidal thoughts, and kind of the worst suicidal thoughts in a 2-week period. Given just kind of the nature of these analyses, this is very exploratory. To our knowledge, we're the only folks to kind of consider how these warning sign pattern differences between people might predict down the road outcomes like reattempt. So we set a p-value of 0.10 or under. All right. So as I said before, we had 5 classes. Again, when you find these classes, kind of like when you identify a latent variable, you kind of give them a name depending on what they endorse and what their behaviors look like. So if we look at the sample of participants in the 5 classes, we had about 12% of our follow-up sample in a class we called high risky behaviors. I'm going to talk about that class in quite a bit more detail in just a bit. We had a class that was their thing that set them apart the most from others was marked sleep deficits. We had a class that was about 21%. That was on the flip side. They kind of slept too much. They had prolonged sleep. We had another class that's 43%. So you can see this is the plurality of the sample that really captured the patterns we kind of saw in those overall analyses that Courtney was highlighting earlier for us. So we called this a typical warning sign class. And then we had a class that their most distinguishing feature is they're pretty clearly heavy drinkers, both in some baseline measures we got and their behaviors before the attempt. So since we have 5 classes and we have these variables that are measured across 2 time periods, so if you have 7 variables in a case and a control, that's 14 variables total across 5 classes, about 70 variables. So that equals a lot going on. So I think in the next slide, Courtney will kind of show you the big picture here. I'm a data nerd, so it'd be really fun for me to walk through each of these 70 bar graphs for the rest of the day with you all and tell you about them. But instead, we're going to have to zoom in a bit and kind of focus on the 2 classes that really told us the story about the extent to which that different patterns of warning signs might prospectively relate to outcomes. So we'll go to the next slide here and talk about the 2 classes I'm going to highlight. Right, so the 2 classes we're going to highlight is this typical warning sign class. Again, this was nearly half of the sample. And what distinguished this class is they really had patterns of warning signs consistent with prior work. These were the results that Courtney was summarizing at the start of the talk. So for these folks, alcohol was a warning sign, interpersonal negative life events is a warning sign, suicide communication was a warning sign, meaning they're more likely to engage in those behaviors during this case period, the 24 hours before the attempt, versus that control period. So that's going to be one class we're going to focus on. The other class of focus is a class we called the high risky behaviors class, and we'll see some data here in a bit to show us why, is they were really marked by a lot of engagement and these risky behaviors, particularly during the case period. So in these hours right before the attempt, the 24 hours preceding the attempt. The other reason we're focusing on this class is this is really the class that differed on the outcomes we care about compared to any of the other classes. So for the rest of my time here, we're going to focus on this typical warning sign class, which kind of conveniently captures patterns that we've seen in prior work, to this group that kind of sets itself apart from the overall sample with its engagement in risky behaviors. All right. So if we look at some data, we got the little bar graph there in the bottom right. I'm not so sure how well you all can see it, but if we compare this latent class of folks, this is about 12% of our sample. The thing that set them apart is one, they drank more during the case day. If you look at this class, the risky behavior class, none of them reported drinking during the control period, but about half of them reported drinking during the case day, during the 24 hours before their attempt. And that rate would be about twice of what we saw in that typical warning sign class. This group also had more nightmares, both in the case and control day. They also had an experience of more interpersonal negative life events. And again, the thing that really set them apart is they had more engagement in risky behaviors. So a couple things I want to add to that. Even though they had higher rates of interpersonal negative life events, even that typical warning sign class showed increases from the control period to the case period. It's just the risky behavior class just had higher levels of this. For the risky behaviors, for the typical warning sign class, this engagement in risky behaviors is not even a warning sign. What does that mean? It means the rates that we see in the control period and the case period are about the same. But if we look at the rates of risky behaviors in this high risky behavior group, we literally have 100% of these participants saying they engaged in at least one risky behavior somewhere in the 24 hours before the attempt. If you compare that to the typical class, they're at less than 10%. So you have a 100% rate versus a less than 10% rate. So these are big differences in engagement in these behaviors. They didn't really differ in terms of sleep or suicide-related communication. All right, next slide. All right, well, now we're going to turn towards our outcomes. So one outcome we really care about is the probability of reattempt. So not surprisingly, the typical warning sign class had a reattempt rate very close to the overall sample descriptives that Courtney shared earlier. Their rate of attempt was just over 18%. But you can see this high risky behavior class had more than double that rate of reattempt, right? Nearly 43% of folks in that class had a reattempt. So those are big differences that you can see in the bar graph there. One thing that was particularly interesting about this is we had all these baseline control variables that Courtney told you about. We're adjusting for baseline depression, baseline problematic alcohol use, characteristics of the attempt, the number of reattempts. None of these traditional baseline control variables significantly related to reattempt. So what it uniquely had a relation to reattempt at a pretty big effect here was this pattern of behaviors in the hours preceding the attempt. All right, another outcome we looked at was the frequency of suicidal ideation. Again, same pattern. The folks who were in the high risky behavior class had a higher frequency of ideation compared to the typical warning sign class. You can see that in the bar chart down below in the lower right. If we took those data and we added some standard deviations into it and calculated a Cohen's d, it'd be a pretty big effect size. The Cohen's d's difference here between the high risky behaviors group and the typical warning signs group is about 0.70. So these are pretty sizable differences. As opposed to reattempt, we did see that many of our baseline covariates here, such as depression, multiple attempt status, and negative reaction to attempt, did relate to this frequency of suicidal ideations or thoughts. But even if we've had models that adjusted for these baseline variables, we still saw this difference between the latent risky behavior group and the typical warning sign group, which means above and beyond these baseline differences that we found, we still had prediction of suicidal ideation based on which of these latent classes you were in. All right. And finally here for the outcome, we had worst suicidal ideation. Again, similar pattern. Those in the high risky behavior class, again, had higher levels of worst suicidal ideation versus the typical warning sign class. Again, you can see bar charts, you can see some means. If we convert this to a Cohen's d, the effect size is even a bit higher. It's almost 0.80. The Cohen's d here is about 0.77. So they're almost, 0.8 of a standard deviation apart from each other. So these are pretty sizable differences. Just like we saw for frequency of suicidal thoughts or ideation, we did have multiple baseline characteristics relate to these levels of worst suicidal ideation, but we still saw these class differences even in models that adjusted for these baseline variables. All right, Courtney, I think it's back to you for discussion and implications and directions going forward here.
Thank you very much, Andrew. Okay, so I know that was a lot of information, and after I finish this part, we can kind of go back and blow up some charts so you can kind of see some information, maybe a little more clearly with a little more time. We wanted to have some time for questions, so I just wanted to say that. So I want to highlight that really this is a proof of concept for us. We weren't, thinking that we were going to follow up these individuals, and but there is a provision of evidence that what our research question was is that these patterns of behavioral warning signs can predict future attempt and levels of suicidal thoughts within the 12 months of discharge among a really high-risk group of individuals. What I was really excited about is that we were able to actually show differences between this really high-risk group, which is the higher risky behavior group, and our typical warning signs group. And this is despite the low N for our highest risk group overall. I mean, if you think about this, we have 132 people, we have 5 classes. This is a lot, especially then we also control for all of these traditional risk factors. So I really think it's a proof of concept for a future study that was designed to look at this from the get-go. Excuse me. So just to briefly kind of review our findings, and then we're going to discuss about implications, is that for reattempt, now the P was less than 0.06, so I don't want to over-verify that. This is also controlling for these factors. But one thing that I thought was really interesting is that none of the traditional baseline factors, even bivariately, predicted reattempt. So this suggests that at least these behavioral warning sign patterns that we talked about are at least as important as those as predicting reattempt after hospital discharge for a suicide attempt. When we're talking about worst suicide ideation, we had the same findings for frequency of suicide ideation, but we also found that the higher risky behavior class was greater in as far as the severity of the worst suicide ideation or frequency than the typical class. I want to just take a moment and kind of discuss what other baseline variables were also significant. So all of these you can think of as over and beyond everything else. So depressive symptoms, which is not that surprising, right? The greater depression symptoms that you have, that was predictive of a higher level of suicide ideation post-discharge. History of previous attempt was also predictive. So these are both things that has been demonstrated in the literature before. So this would be not individuals who it was their first time attempting in the index hospitalization that we're talking about. So this is probably now at least their suicide attempt would be predictive. And then this negative reaction to attempt, which I'm highly interested in moving forward. I think this is something that has not been investigated as much as I would say that needed to be. Is something fairly easy also to ask participants about what their immediate reaction about their attempt was. Was it that they were glad that they didn't succeed? Was it that they were somewhere in the middle? Or that they really wish they had succeeded? And that's something that I collected more pilot data on more questions to kind of flesh that out for this study. But again, we only had 30 individuals who attempted, and we only could then get those kind of reactions for that attempt at follow-up. So I was trying to get more information about that reaction as well. So, but I think that's something that I would say is worth conducting further research. And like everything that is going on with the field right now, this also shows that predictors of SI are not the same as predictors of their attempt, that we can't assume the same things predict. Okay, so what are some potential clinical implications for this? Well, if we can identify someone's behavioral warning sign pattern, this could really assist with providing, a treatment target during hospitalization that is more individualized. So risky behaviors group, I'll use it as an example in a minute. It could also inform more precise discharge decisions. Like, okay, so if there's a group that is kind of characterized by interpersonal negative life events, let's say, and drinking, which is not one of the ones that we highlighted here, but maybe that's finding out more about whether that it has resolved before they get discharged, and kind of how much we should follow up with that individual. Also, facilitating evidence-based referrals. Someone's reason for attempting or what their warning signs are prior to that attempt is something that I don't think necessarily is taken into as much consideration across the nation when thinking about discharge versus maybe more diagnostic patterns about kind of what treatment they need going forward. And it can also guide longer term prevention efforts. So there always is not always, I'm sorry. A lot of times there is a disconnect between hospitalization and when people get into outpatient treatment. Some people will never take on that referral to go into outpatient treatment. So this really suggests that maybe by identifying these behavioral warning sign patterns, we can kind of think more about these implications moving forward. So for instance, with the risky behavioral warning sign group, like Andrew specified, that's what really distinguished them. It didn't mean that the other ones weren't warning signs for that group. They had all the same warning signs as they did for the typical group, right? But their levels were different, the magnitude were different. And what distinguished them is they also had the risky behaviors. And I think Andrew, highlighted it really well. About 100% of this group engaged in a risky behavior that was not alcohol use, separate from alcohol use on the day of their attempt. So if that's the case, maybe we could have more intensive follow-up. Okay, so thinking about really monitoring those risky behaviors afterwards and for a longer period of time, and provided targeted recommendations for treatment to lower their attempts. So for instance, maybe it's okay if someone is more amped to act on their impulses or negative affect. Maybe mindfulness might be something to start with. So you kind of can be able to stop that. DBT skills, things like this that we know have been successful for a variety of individuals. Okay, so as far as our strengths, I'm really proud of that we were able to recruit into our follow-up study such a large percent. I'll be honest, I didn't think we would get that much at all. Especially since we weren't tracking these individuals at all. And there also weren't differences from people who didn't participate and who did participate. So I think that was a strength. We used, as Andrew said, an a priori class solution for these prospective analyses that was based on our baseline sample when we didn't know that we would have this funding or that we would be then restricting it only to one site. And something we didn't mention, but all of these analyses controlled for the length of time from their discharge to the interview, as well as the traditional risk factors. So limitations are kind of also our future directions, is that we really need replication in larger samples. So I think 132 we would think is a pretty large sample, but not if you're really trying to focus on not just only the when, but the who is at most risk kind of going forward. Also, we need to assess outcomes more proximal to discharge. Again, we assessed the rate of attempt and the level of suicide ideation, focusing on the 12 months post-discharge, but sometimes that was 5 years later. Now, I'm always giving the extreme, right? Sometimes it was only 2 years, but we had to really work to reorient using kind of procedures that Kate has developed within the SASE count to get people back into that time period. But ideally, we would be looking at it, from the get-go, 1 month, 3 months, 6 months out, etc. And this has actually raised a lot more questions for us. We did not plan for this, and so there's a lot of other baseline characteristics, like for instance, negative urgency, that I would have liked to include to see differences between these classes. And so hopefully that can be our future directions. So as far as our acknowledgements, I want to acknowledge not just this study, but for all of my studies that have led up to this, the medically attended patients that have taken time to participate. Research personnel that helped collect this data is Meg Martin and Harrison Dickens, who Harrison is now in graduate school, and so he may be seeing this. Sarah Cohen, who helped with this presentation, who's now at University of Michigan, and my dear collaborators, Kate Comtois, who invited me, and who was a consultant on this project, really helped assist with using kind of the SASE count and the SSI worst. And Dr. Ken Connor, who was my MPI for the baseline study. I also want to acknowledge the funding agencies, not just DoD, who funded these 2 projects, but everything that led up to this. I started with a pilot grant from AFSP that I will forever be indebted to. And then even since then, this work now has been entirely relevant to an IAAA grant on warning signs and now an IMH R01 that is in the field. So I feel very indebted to them. And so we wanted to leave some time for questions or comments. And Andrew and I would be happy to answer any questions that you have. Would you mind, actually, yeah. Does someone want to facilitate the question?
Yeah.
Okay, thank you.
Happy to. Any questions for Dr. Bagge, Dr. Littlefield? Thank you so much for sharing this amazing work with us. It's so cool to hear you talk about using the when to identify the who. I thought that was such an interesting way to look at it, and really kind of opened my mind to that. And I think if folks aren't jumping in with questions, I'd always love to ask this question. It's different from limitations because I feel like but I think something that we could also learn from too is like, what were some of the things that came up during this study, whether that's from the data collection phases all the way through to kind of the data analysis phase, surprises that kind of came up like methodologically that you weren't really anticipating, that you were kind of like, oh, I had to adjust for this, or this was something we didn't encounter before, or this is something that that kind of surprised us a little bit about these participants or this way of collecting data or doing this type of study.
I can talk about like locating people. This study finished in 2020, so I actually had to like go back to my notes. This is also when before I was at the University of Michigan, and kind of I just remember how difficult it was. And I think the thing that I want to share with people is always ask for permission to recontact, and through a variety of ways. So medical record was very, very helpful for us. And because a lot of people, like with Epic, this was like when Epic just started too, but they'll change their address. And so then you're able to find that. Also just manpower. We had a lot of volunteers that were searching Google. We found obituaries, and at that time you could have a Facebook account that like you could look for people through it. We didn't message people, but we could look for it. You no longer can do that. But that was really, really helpful. So I think just the amount of time to find people, and then once you figured out where they are, how you can contact them without to be successful without like them like getting too angry. So one of the tricks we had is leaving a message that we're interested. You said follow up. If you're absolutely not interested in this, please let us know. Call this number. You can call it after hours. So we made it very easy for people to say no, which I think was helpful. And not a lot of people did. But I think just knowing that we weren't just trying to get them was helpful. I think I'm going to pass it to Andrew in a second, but I think the thing that was most surprising for me is how many people died or were in jail. If you think about that, that percentage is pretty large. That I thought everyone would be eligible. I mean, I didn't really think about, well, they're not eligible if they can't do the interviews. That's a different way of thinking about eligibility. But out of those 6 individuals, 2 we know are suicides. We actually confirmed it with their family. It wasn't in the obituary. 1 was an accidental overdose. And then those were in 12 months period. And then the other ones were natural causes, but those were outside of the 12-month period. Well, one of them we didn't know. We never could find that out. So this is a really high-risk population. And so one of the things that we're doing is we're actually going to be going to the CDC and asking about mortality for all of my samples going forward, given the very high rate. And Andrew,
I've got sorry, I'm going to jump in with a quick question. I'm Julie Richards from Kaiser Permanente here in Seattle. I was curious how you measured alcohol use, if you used like the audit C or something along those lines. Also curious about how you measured interpersonal difficulties. I think that was the term you guys used. So I was just curious about a little bit about that.
So it's different depending on if you're talking about the win or in the baseline factors. So looking at the timeline follow back for suicide attempt, it's basically taken from the alcohol literature. So we would present them, really inform what is a standard drink, have lots of different pictures of what, I learned a lot about alcohol, what a handle is, and really calculate that, give them that knowledge for that, and then asking when they drink any kind of alcohol. And a tip for non-alcohol researchers, saying alcoholic, like a beverage that contains alcohol, because sometimes when you say an alcoholic drink, they always think that you mean like whiskey. They don't think beer. So I learned that.
They've also moved away from it because they consider alcoholic stigmatizing. So you're not even supposed to say that.
Exactly.
So.
Yes. Thank you. And Andrew's like the premier alcohol researcher too. So thank you for jumping in. Interpersonal difficulties. So this is something that Julie, I can send you. This was published in Journal of Abnormal, I think like in 2013, where we validated interpersonal negative life events, different categories using the timeline follow back. But it's really just another stimuli, right? Where we ask people different things that if they occurred and when they occurred. And so interpersonal, how we defined it, it was really a disruptive disagreement. So it wasn't just like a little like snippet and any ending of a relationship, you know, of a breakup, things of that nature. And as you know, that's one of the probably the most consistent findings we have before a death by suicide or suicide attempt. And for baseline, we did not have an interpersonal difficulties scale. And I'm not aware if that is predictive of reattempt for attempters. I'm not sure. But we had the audit. And so problematic alcohol use, those numbers that I showed were based on the full audit.
Thank you.
Other questions?
Do you mind if I ask Andrew what he found? I wanted him to answer your question.
Yeah, sure. I'll answer your question, Courtney. I thought it was going into this, it really hinged on how well the recruitment follow-up went, because as Courtney alluded to, it's one thing if you're just trying to answer overall questions, like is alcohol use a warning sign or not? But once you start taking your sample and dividing it into so many different subgroups that show similar patterns in terms of warning signs, like sample size becomes a primary concern. So I thought it was amazing that we got the number of folks that we did for follow-up. I was also, the data, as you could tell, it kind of told a pretty clear story that these group of individuals that really endorse these risky behaviors, particularly in the hours right before the attempt, it's not, you didn't have to do a lot of fancy statistical analyses to see that this group was different from the other classes that we identified. Their rates of reattempt, even though they were just 12% of the overall sample, they accounted for a good chunk of the overall number of reattempts we saw in the sample. Their rates were higher in terms of the suicidal thoughts and the severity of that. So I thought it was interesting how that group just really set itself apart, because we highlighted the typical group just to show a typical representation. But the reality, the other three latent classes or groups of folks we did not really have a chance to talk about, they were pretty similar to the typical group in terms of these outcomes. So it was really interesting. What are we capturing here about these folks? Because, on one hand, you could think where maybe these behaviors are not going to prognosticate anything because you're in a crisis situation. These are hours right before an attempt. Maybe they're representative of you, maybe they're not. But you could take these behaviors in these hours before the attempt and see the changes into a control period for warning signs. And it did relate to pretty big differences in the outcomes we looked at. So I thought that was interesting, if not surprising, for what we did. And the fact that we, again, really nailed ourselves down of what we were doing. This was before pre-registration was such a thing and things like that. We basically had to pre-register our analyses here by saying we told the funders before we started collection, these are the classes and this is what we'll compare. So to walk in with that, not really knowing how they may or may not differ on the outcomes, I thought was kind of a more risky test than perhaps what we sometimes have. So I hope that answers your question, Courtney.
It's always so interesting to hear the different things folks run into and what surprises them about the various studies. I feel like it's often so unexpected, and it's not the things you talk about in a research talk, but just kind of really interesting behind the curtains things. I think we're about 2 minutes out from the end of our science meeting. Is there any last pressing questions for Dr. Bagge and Dr. Littlefield?
Anna, I have one. Anna Radin. I'm in Boise, Idaho at St. Luke's Health System. Thank you so much for the presentation. It was really, really fascinating. I feel like the questions you've started answering are things that we've been asking for a long time. And I just wondered if you could say a little bit about, once we have nailed down with confidence what kind of the when and the who, some of the predictors with more confidence, what do you see as kind of the public health implications of that information? How do we apply that? What do we do with that information? Can you just talk a little bit about that kind of next step once we're like, yes, this is it, now we know?
The Holy Grail.
Yeah.
I think it's going to be a while. I'm just be completely honest, and it might not even be in my research career. I think what we have to do is more research that integrates the who and the when, and usually it's kind of separate. And when that does happen, then I think the public health implications is that we can start to determine when is someone more likely to attempt suicide, and once that has occurred, right? What is it about that we can keep people safe? So thinking about post-discharge. So our treatments and how much we follow them up, and what are ways of doing that? Can we use, for instance, EMA going forward as a clinical tool? I think there's a lot that can be done, but it's really hard to say until we actually have that evidence. And really, this is going to take a very large study. So things that I haven't addressed is all of my people have attempted suicide. So it's not like we are capturing them, before the attempt. What we have found, and people in this group can talk to it, it's very hard to capture a suicide attempt using EMA. And so this is, for me, just looking at the public health significance of people didn't know why, what were basically the triggers for a heart attack way back when. And so what they started doing is asking people with a heart attack, right? Kind of like with COVID. We didn't know what was causing it. So you first, talk to the people where it's relevant. And so they did this with in-person design to do it. And then they found, then you can kind of move outside of that to prior to an attempt. But I don't really know right now of a good way to really capture those hours in a different way. So I think that, to make a long story short, is that it's not easy, and that we're going to need a combination of groups to do this, that are EMA researchers, that are, prospective researchers, that are near term, like focally, all combined together to get that. But I really think that in this kind of data age, if we can do that, then we can really make some, especially with AI, some pretty good estimations of when and who.
Awesome. Thank you so much, Dr. Bagge and Dr. Littlefield, for coming in today. And thank you, Dr. Radin, for that question. I think we learned so much from the presentations, but also kind of from the various questions that are being asked. So thank you all so much for coming to our monthly science spotlight at CSPAR, and we will see you next month. Julianne, I just realized I forgot to grab what's on next month. Do you have that pulled up by any chance?
I do not. So I also don't remember what's up first for next month.
Well, I will put a plug in for the mailing list. So please sign up for our mailing list so you can get updates on what our next spotlight will be. Thank you again so much for coming in today, Dr. Bagge and Dr. Littlefield. Take care, everybody.
Thank you.
Thank you.